Now we're going to talk about miscellaneous antibacterial drugs. They're not miscellaneous, meaning it's not important, because you're going to see these a lot, including fluoroquinolones, metronidazole, there's daptomycin. You won't see that as much. Rifampin is used for tuberculosis, rifampin, Bacitracin, and polymyxins. The most common ones you'll see, fluoroquinolones, you'll be giving Levaquin IV, very often inpatient, and metronidazole is given very often through the IV as an inpatient. So we'll get started on that. All right, so these are broad spectrum agents. Remember, broad spectrum means they can treat a wide variety of infections or area parts of the body that has an infection. What this one does, it does not work with the cell wall, but it gets right into the bacteria. It disrupts the DNA replication, so it won't divide into more bacteria. So all of these can be given orally or IV. So you may have already seen Levaquin or levofloxacin or ciprofloxacin given orally as an outpatient, or maybe you've had it. They really shouldn't be used orally unless you really need it. But unfortunately, this is one class that's just overly prescribed again. One of the scares that fluoroquinolones recently came out with is tendon rupture, the Achilles tendon rupture. So as an outpatient, I'm always asking, okay, are you an athlete, elderly, you want to be careful. So if you're an athlete and a runner, a chronic runner, you know, meaning like just really like running miles every day or training for a marathon, I always want to be careful with giving a fluoroquinolone to them because of the risk of a tendon rupture. It is low, but it can happen. Avoid in patients younger than 18, and there's always a risk to all patients older than 60 if you're taking steroids, and those who've had some transplants, kidney, heart, or lung. Also, to go back to this, it also can cause confusion, especially in elderly people. And what's hard with this medication is that usually we use it for when you really need it or last resort, and a lot of times elderly people really need these medications, so you have to be careful with them and watch for side effects. If you see confusion in the elderly and they're on a fluoroquinolone, it's probably from that. I see that a lot with, or used to see that inpatient with IV Levaquin. I actually saw that with my grandma too. She just, oh my gosh, she turned very mean when she was on that drug in the hospital. All right, the first fluoroquinolone is ciprofloxacin. This is a broad spectrum, gram-negative, some gram-positive. It works with the DNA again, and it's the drug of choice for anthrax, but it's also used for respiratory infections, UTIs, GI, bones, joints, skin, soft tissue. So it's used for a lot of things. What we see in outpatient setting, it's used for a lot of UTI issues, especially inpatient too. You'll see that for UTIs. In the outpatient world, ciprofloxacin in primary care is given if they've had more than 3 urinary tract infections in a year, or it's just maybe they did a culture and it's resistant to the macrobid, which I'll show you a chart on another slide set on that type of class, or the Bacterial. All right, so there's some bacteria resistance to staph. These types, you don't have to know these bacterias at all. Even for your NCLEX, you wouldn't really have to know all these other than possibly understand really what MRSA is. So I know you'll most likely have to know what that is. And just know that I'm not really sure what increased drug export means, but there's some bacterial resistance to it. It means that there's the alterations in DNA and has this bacteria resistant to these specific bacteria. So ciprofloxacin, you can get some mild GI effects, just like with any antibiotic. You want to take it with food. And as I talked about CNS, it can get some confusion. I see it more with levofloxacin, but you can still see it in here. Rarely seizures, the tendon rupture, phototoxicity, and you can get yeast. You're more likely to get some yeast infections with this one, and an increased risk of Clostridium difficile. So know that with the cipro, it's common with most common with clindamycin, but fluoroquinolones can also do that, because remember, it wipes out the good bacteria in your GI tract as well as your bad bacteria, and it makes the bad bacteria overgrow. So we all have Clostridium difficile in our colon, but if you're wiping out all the good bacteria, that can overgrow, and then you end up with this infection. Older patients, I mentioned before, the confusion, psychosis, visual disturbances. You can have some hallucinations, myasthenia gravis, which is rare. There's some drug and food interactions, so you have to, I know we've already gone over now the antacids, so you want to make sure you're taking those separate from these, or tell them just not to take those at all, like your Maalox, milk of magnesia, and that kind of stuff. The sucralfate, which we talked about too in the GI section. Also some milk and dairy products. You just want to make sure you're taking it apart from that. Also, it can mess with your warfarin levels, tendinidazole, which is an antifungal drug, and theophylline. Theophylline's not used as much anymore. We went through that in our asthma or our pulmonary area. The tendinidazole, it's an antifungal drug. You see more metronidazole used more. Now these are all the fluoroquinolones. You will definitely see levofloxacin. Not so much ofloxacin. Ofloxacin I use a lot as an outpatient for ear infections and eye drops like pink eye. Moxifloxacin you won't see too much, norfloxacin, gemifloxacin, but you really should know your levofloxacin and your ciprofloxacin. Those are the two that are that you're going to see all the time. Now we're going to go to metronidazole. That's not a fluoroquinolone. Metronidazole is one of those miscellaneous medications. It's used for protozoal infections, infections caused by anaerobes, H. pylori, which was in your GI area. Adverse effects, neurotoxicity, allergies, superinfections. Daptomycin, you're really not going to see too much. It's called cubicin. It's a new class of medications. Again, I've talked to a couple people, including my daughter, and they haven't seen it in inpatient. But just know that we've really had to come up with some new antibiotics, because we've really become scared as a society to run out of antibiotics when we have these superbugs coming out. But these kill virtually all gram-positive bacteria, including MRSA. So you don't want to use this unless it's absolutely necessary. All right, so no significant drug interactions, possible muscle injury. It's an IV medication, but again, this is only used last resort. Some other additional ones, rifampin, that's been around for a long time. It's used for tuberculosis, also used sometimes for meningitis and prophylaxis of meningitis due to H. influenzae. When you see Haemophilus influenzae, don't think they have the flu. That's just a type of bacteria. Rifampin is used for traveler's diarrhea. Cipro is really used now because it's just less side effects. It's just better to take than the rifampin. Although that's still out there, you may see that in other countries. This one also, it can be used for C. diff, although I've not seen it used before at all. Bacitracin is used for topical, so you've probably heard of bacitracin for bacterial infections. So if we have like bacitracin packets in the office that we use when we do like certain mole removals and things like that to put on top of it. Polymyxin B is another topical treatment used for eyes, ears, and skin. So that's another skin thing that it can be used in that area for any kind of rashes. And that's it.